Great. All right. Well, let's get started. Welcome, everyone, to this World Hepatitis Day webinar called Policymakers Can't Wait, which is part of our World Hepatitis Day discussion series. We're very honored to have a great panel from around the world to lead this very important discussion, and we really hope that we hear from all of you as well as the conversation goes on. So just a couple of housekeeping points just to start with. We are offering simultaneous translation. So maybe we can go to the next slide, please. So if you're not familiar with it, just on the bottom of your Zoom screen on the right, you'll see an interpretation button. So just choose the language that you would like to hear throughout the entire webinar. And then you will see. Next slide, please. There you go. There's the button. So please choose that. And throughout the session, if you have questions or comments, of course, feel free to put them in the chat or in the Q&A section, or please raise your hand and we'd be very happy to open your mic so you can take part in the conversation as well. And please do introduce yourselves in the chat as we go along. So this is a very important topic today, and it's a very important time of year for hepatitis elimination. And we just thought we would start out with one of our videos for this year's theme, Hepatitis Can't Wait, to kind of set the stage for the discussion that we'll be having. So could we play the video, please?
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. 9 out of 10 people with hepatitis don't know they have it. Don't wait. Get tested. It could save your life. Hepatitis can't wait.
So this really comes on a landscape where we still have 1.1 million people dying every year from viral hepatitis-related illnesses. 43% of newborns still receive, only 43% of newborns receiving the birth dose vaccination. As the video said, only 1 in 10 people living with viral hepatitis know their status, and only slightly more than that, 20% of people with hep C know their status. And just in terms of what needs to be done and how far we need to go to get where we want to be, hepatitis C treatment would need to increase threefold to reach the 2030 elimination targets. Next slide, please. And although all the countries signed up to the commitment to eliminate viral hepatitis, only 124 countries have developed or are developing hepatitis plans. This was according to, I think, 2019 data, so that there might be a few more, but still not all these years after the target was reached, still quite a small number of countries even have a plan in place, and just over 40 actually have dedicated budget lines to support those efforts. So, we have a cure for hepatitis C, we have a vaccine and effective treatment for hepatitis B. Many of those, in many countries, these are now relatively affordable. So what's really holding us back? Why aren't we moving forward in the way that we want towards those 2030 goals? So we really hope today we'll be able to really talk honestly between each other and really kind of get down to the reasons why. Because if you look at hepatitis elimination on paper, it seems like such a no-brainer that this is something that that more global attention should be put on and that national governments should be engaging to. So today we really want to kind of talk about in an honest and straightforward way, what's kind of standing in our way for action on a national level in terms of parliaments and health systems, and what can we do and how can we communicate better with parliamentarians and between parliamentarians and civil society to really make that change happen. So I'm just going to introduce our illustrious panel today, and maybe it's better if we just turn the slide off just for a moment, just so people can see everyone's faces while I do the introductions, because otherwise it's just looking at the slide. So I'm just going to do this in the order that I have them here. So Mariam Yashi is the Global Health Envoy and Regional Chair for Eastern Europe and Central Asia at Unite, the Global Parliamentarians Network. She also chairs the advisory board of the Tbilisi Medical Academy. Mariam brings 23 years of experience in public health from 26 countries. She's a former member of parliament, chair of the parliamentary committee, and deputy health minister, having led the design of the hepatitis C elimination program in Georgia. And we'll be talking a lot more about that later as well. Gisela Scalia is a representative of the Argentine House of Representatives for the PRO party, and Elias Juntos for El Cambio, pardon my pronunciation. She serves as a representative for the province of Santa Fe, Argentina. In 2013, she was elected for the first time and was re-elected for a second term in 2017. She has been vice president of the Santa Fe province PRO party since 2020. She also serves as co-president of the Latin America at the Global TB Caucus, and she holds the regional chair for Latin America and the Caribbean for Unite. Next is David Sergenko, and he is a Georgian physician and healthcare administrator. He served as the Georgian Minister of Health, Labor, and Social Affairs, and on the 13th of June 2018, he was named Minister of Internally Displaced Persons from Occupied Territories, Accommodation, and Refugees. He is now Deputy Chairperson of the Parliament of Georgia. Mr. Mohammed Usman is a former member of the Nigerian Parliament for the Kaduna State. As the Deputy Chair committee of the Committee on Healthcare Services, he sponsored legislation and motions aimed at strengthening the Nigerian health systems. He's a close collaborator of John Hopkins IVAC projects in Nigeria. He is also the chair of the National Advocates for Health and deputy chair of the Legislative Initiative on Sustainable Development. Danjuma Ada has been a fierce and vocal advocate for people living with viral hepatitis in Nigeria and regionally in Africa. He is the executive director of the Chargo Care Trust and the Center for Initiative and Development, a nonprofit healthcare organization in Nigeria. He is also the national coordinator for Civil Society Network on Viral Hepatitis in Nigeria, a network of organizations that held the first Nigerian Hepatitis Summit in 2018. He is currently a fellow of the prestigious New Voices program for the Aspen Institute and is president-elect of the World Hepatitis Alliance since January 2021. Sorry, excuse me. I just have a small technical issue. There. Sorry, excuse me. And finally, Marco Kareniak is the current president of the European Liver Patients Association that represents 31 liver patients associations from 25 countries. He has 2 master's degrees, first from business and economics, and the second in international relations and diplomacy. His work is focused on patient advocacy at the highest European level and is connected to changing the landscape for liver patient care. So welcome to our panel. And without much further ado, let's go into the first topic for conversation, which is really what is standing in the way of countries acting on this global commitment that was made to eliminate hepatitis in 2030. What is really standing in the way? What kind of issues have you had as parliamentarians when discussing hepatitis and the barriers that you faced? So maybe we can start with Gisela, please.
Good morning, everyone. I'm going to speak in Spanish. Acá en Argentina, creo que tenemos...
In Argentina, I think we have something that is very important currently in this precise moment, which is to advance in the law reform of HIV/AIDS. It is a law that was pioneer at the time in our country. It is a law that has been in vigor, in force for 30 years, and that what it requires from us, for the parliaments, an effort to radically change the paradigms in which that surrounded this law and this journey, to include hepatitis B, hepatitis C, tuberculosis, malaria, and to have a more comprehensive law for non-communicable diseases, but diseases that we have to be very focused in what we need to do. And we believe that is one of the challenges that we face in Argentina. But also, I have to say that despite this, regardless of our efforts that we have for between political parties for advancing these laws, we do not reach the result that we aspire. That is that this reform of the law that is comprehensive, that has been pushed forward by the civil society, and that has been signed by all the congressmen in Argentina, we still do not have the results we want, that it is on the table, that it is in the discussion. Maybe it has been some interference with COVID, and some that we should also pay attention to other health topics and not be focused only in COVID. But this is something that is happening in Argentina. On the other hand, I believe that if we look at the barriers, the obstacles that we face to reach the 2030 eliminating hepatitis, Argentinians, we have to work more together with Latin America, more work toward prevention policies and communications strategies. These are actions that sometimes from the standpoint of the parliaments are not being done. The governments are not doing it either. We are not placing enough focus or attention in all the work of communication to talk about these diseases, to really have joint work in these issues. And I think that is an important obstacle today in the region. Many of us ignore what is going on, what are the real numbers, and how to approach them. And frequently, the lack of a timely and a precise diagnosis is one of the obstacles to achieve better results. That is why, to synthesize this in my first presentation, in Argentina and maybe in the region, we should advance with frameworks that are non-discriminatory, that are more encompassing for these diseases, for their treatment, and what the state has to commit in terms of treatment, and also for diagnosis. To advance in the reform of the laws, which is currently our main challenge for the civil society and the parliament, and that would be a milestone for the region after 30 years of having approved the HIV/AIDS law. On the other hand, without any doubt, to set as a priority for all parliaments how we can disseminated information, that we're all aware of the challenge that we face, and that the state can make a direct investment in prevention and communication. It's not only about financing, and that's interesting, but how we can be more creative, and how we can get involved as parliamentaries in these topics. I think COVID will teach us many lessons. It placed health at the center of the discussions of the congresses and the parliaments that we had not seen in many years. Now the parliaments are talking about health and about global health. This is a great opportunity in the framework of global health that we can start talking about other topics. For example, hepatitis. I think that we are facing a great challenge, but also a great opportunity so that we can use this sad opportunity of COVID. It is not the way we wanted to place global health in our congresses, but it was with a sad experience, with a terrible disease that is challenging. In Argentina, we have more than 100,000 deaths, but this should turn the spotlight in global health, and this will be a great opportunity for us to talk about these topics.
Excellent, thank you. Yeah, I think the impact of COVID had on the conversations that everyone is having about health is really changed things, and it'll be interesting to see how this develops and how hepatitis can be part of that ongoing conversation. That's definitely one of the main focuses of our kind of strategy going forward, is how we make the most of that. Maybe now we'll move to Mr. Mohammed Usman from Nigeria. It would be great to hear from you about your experience around parliaments in Nigeria and taking action on hepatitis.
Thank you very much, Kari. Let me first start, by saying, that hepatitis is a major public health concern, in Nigeria. It's a concern not only to the parliaments, but to all tiers, of government, the federal government, the state, and the local government level. Because statistics, today has shown that over 20 million Nigerians are infected by hepatitis, either B or C. That means in Africa today, Nigeria is number one in terms of having the highest number of infected persons of this disease. Now, when you consider the fact that Nigeria today has a population of about 200 million, and within the next 30 years, by 2050, Nigeria might become the third largest populated country in the world, it becomes a major source of concern. Policymakers must really take decisive action to stem the tide of this disease. Now, there are so many challenges which we are really having, barriers to eliminating hepatitis, which hopefully between now and 2030, which is the goal, all things being equal, will achieve. So beyond financial, constraint, there are two major barriers. The first is the issue of service barriers. When you look at the allocation of health infrastructure in Nigeria today, including the health workforce or personnel, they are concentrated, in the, or rather skewed towards secondary and tertiary education, level. We have a majority of population at the grassroots level and without having access to medical treatment of hepatitis. And this becomes very dangerous, considering, like I said, the population of 200 million. In fact, only about 10 million, one would say, live in urban areas, live in cities. So that means if you are to x-ray it, you might say that about 170 million Nigerians today who are within the rural areas do not have real qualitative healthcare attention. At the local government level, that's where we have the primary healthcare centers. The primary healthcare centers, while in so many villages and rural areas, they are even unavailable. Where they are unavailable, they are not functional. They lack staff to really administer. There are a lack of facilities, like equipment, and then the manpower is even there. And I believe statistics has shown that even medical doctors today in Nigeria, less than 200 experts, or rather have studied hepatitis, at the maybe degree level. So that means so many of the ones, that have even no training, not to talk of administering, medication treatment to hepatitis victims in Nigeria. This is a major barrier. The second major barrier today in Nigeria, following this, is also issue of vaccine hesitance. A lot of, because of factors, issue of illiteracy, issue of cultural factors, issue of religion. A lot of mothers today refuse, to take their children, for vaccination. And that is why the latest, or rather the last demographic, survey shows that almost about 4.3 million children are missed out of immunization. That is children who are under 5 years of age. So definitely this will have a great impact in terms of number in the near future. And it's a major trend today, which, if not checked, will continue, to blossom. The number, as our population keeps on, growing, the number will keep on growing also. So these are the two major barriers. Apart from finance, maybe probably when I come next again, maybe I might shed light on finance. Thank you very much.
Excellent. Thank you. Thank you. And I just see that we have a hand raised from the participants. I think, sorry, I just have to open the right window in order to do it. Tan Kim, would you like to open your mic and make your comment or ask your question, please? Or maybe Tan didn't have a question because he's taken his hand down. If you do have a question, please go ahead. Okay, James, you have your hand up. Would you like to ask a question or make a comment, please?
Okay, I am so happy regarding this forum, and I want to thank Dr. Danjuma Ada for bringing me on board. I am the chairperson Nigerian Network of People Who Use Drugs. And one of the things I would like to point out is that in Nigeria currently, just as is rightly said, that we have over 20 million people living with hepatitis in a population of over 200 million. Is very, very alarming. And I'm trying to see how we can be able to step up the advocacy. In what way can we do that? Because as it is in Nigeria currently, hepatitis is not considered that much a big public health implication. We have the HIV, we have the malaria, we have the TB, having a lot of big funding, big strategy and implementation. But my concern currently is when I go to meetings as a drug user, as a survivor, I speak and they will tell you there is no funding for treatment. Many of my committee members are carrying hepatitis, but they don't even have support for treatment. When they even are positive, can they really afford treatment? Can they really even have access to vaccination for those who are not yet infected? Those are some of the concerns, and particularly the women group in Nigeria, the key population women, young girls, vulnerable key population women. Are they having access to prevention, vaccination, and prevention to mother-to-child transmission of hepatitis, so that at the end we can be able to achieve that elimination of 2030? My concern is advocacy for funding. I don't see that happening in Nigeria, and it's a source of concern. How do we build on it?
Thank you so much. And I think that comes down to the question. I mean, I think finance is quite often the question when we have conversations on a national level about hepatitis programs and action being taken, that they're very expensive, that the budgets are already formed. And I mean, I think we've seen, from the current crisis that if funding can be found, if there's a political will to do that, right, So I guess that question is how much is it really just about finance, and how much is it lack of like understanding of hepatitis or lack of empathy for people living with hepatitis, and how do we get past those barriers? Don't know if any of our panel would like to comment.
Let me. Okay.
Yes, please.
Let me comment. You see, issue of advocacy is something which is of a continuous nature. Really, what is happening, you see, in Nigeria is that concentration, attention, advocacy is usually at the national level, while the subnational level, are left without advocacy, without people, calling on the governments. Most of the NGOs today that we have in Nigeria concentrate at the national level. Nigeria has 36 states, and in each of these states, in fact, some like Lagos, Kano, Kaduna, they are well populated, millions, so we must to ensure, check up this issue of finance. Advocacy must be pushed at the state levels, the governors, the state houses of assembly. As a legislature, I will love a situation whereby we will advocate to the state levels, the speakers, the chairman of appropriation, the chairman of committee on health at the state level to step up, to ramp up their budget. If that is really done, I believe we might say we'll begin, to mitigate this sorry situation that we have in Nigeria. Thank you.
Thank you very much. Danjuma, would you like to come in on this?
Yeah, thank you, Kari, and thanks a lot to the contributions. Now, if you ask me what is standing in the way of countries acting on the global commitment to eliminate hepatitis, I would put it back to us, the advocates. I would drop the blame on our doorsteps, that probably we have not done enough to push the needle, to push the discussions around hepatitis in terms of raising awareness. HIV got global momentum because of activism, because of the push and the noise the advocates made in driving the message about HIV. They had to do the placard carrying, the picket offices, more like real activism. But the advocacy about hepatitis, I'm glad that yes, it is gaining momentum now. But how much of this message have we gotten to the ears of decision makers? I'm very happy to have Malam Mohammed Usman from Kaduna State. I'm being a Nigerian. I know what effort we made to get even the Federal Ministry of Health's attention about hepatitis in Nigeria. And I'm glad he brought a perspective which we are addressing now, and which is state-based advocacy. And that is what got my state in Taraba to be the first state to initiate a hepatitis program. And that is the approach we are looking at now, to get state governments also commit. But believe you me, we need to move this needle. We need to push, shake the tables in order to get attention about hepatitis and to get financing. Can't we get, that's what happened in the HIV world. I remember several years ago, you look at messages about hepatitis, about HIV, they bring the human angle, they bring people that are almost dying, they bring people that are, and that touch the human chord in advocacy. But most of our message about hepatitis now, there's very little linking even hepatitis advocacy to liver cancer. We only bring the sweet messages about hepatitis, but we don't see the patient. We don't bring the human angle. We don't see people with ascites being projected, people with cancer that needs attention in order to mitigate hepatitis. Those messages are missing, so people don't even connect the end-stage liver disease, the ascites, the liver cancer to messages we drive. So we need to move the needle, and I think we need to do a little bit of human activism to get the right decision makers to make decision on hepatitis over.
That's great, thank you. And maybe speaking of hepatitis is a good opportunity to bring Marco in. because I know ELPA has done some incredible work about bringing hepatitis onto the cancer agenda at the European Union level. So Marco, over to you.
Thanks again. Thank you very much first for the invitation. I'm honored to be among such high-level speakers, and I just wanted to say something about the public diplomacy. So sometimes you need to create an opportunity, and sometimes opportunities are created for you. When the members of the European Commission were re-elected, the European Commissioner for Health was Stella Kyriakides, and she was a former activist in a patient movement for women with breast cancer. So I think this is an opportunity that was just given out to us, and we worked very hard from the first day that she started her mandate to establish a level of trust. Because I think that we are saying things also in a matter of trust. Every parliamentarian here, he knows that he gets like 100 different messages a day. Who needs financing for what? And you need clear messages, which I think that World Hepatitis Alliance has provided several years in a row, very, very clear what needs to be done and how to do it. And I think we should identify the possibilities. And of course, the liver cancer is a great possibility because the European Union has devoted its part of the finances to start a European beating cancer plan. And we work very hard to try to provide a broader perspective on cancer, because at the beginning, the plan didn't even allow non-communicable diseases to be included, communicable diseases to be included into non-communicable plan. So we spend a lot of time convincing them, if you lower the number of cases of hepatitis, you will also lower the number of cases of cancer. And that was like the main goal for the last 2 years. And I think we were pretty successful in getting into the plan. And I need to admit, and I do agree with Danjuma, the finances is always a problem, and it's still a problem. And we try to build up bridges, to build up trust, to present the clear data, and that this needs to be done now. And there are greater benefits in stopping hepatitis than just financial ones. Thanks.
Thank you so much, Marco. And I think that's so important about, we don't just want to be talking about liver cancer in the hepatitis space. We want the people in the cancer space to be talking about hepatitis, right? And that's not just like on a policy level, but that's also like on a parliamentarian level, that to realize that, hepatitis is an integral part of, reducing deaths from cancer, reducing the burden of NCDs, in maternal and child health. For all of these things, hepatitis plays a role. And I think there's a real opportunity for us to be able to mobilize resources across health systems. So even without a huge new investment in hepatitis, if we can really activate those other areas and get them to be working for hepatitis, then we're going to get to our destination much quicker. So maybe now we can talk about actually a country who has had a very successful hepatitis elimination program, which is Georgia. And we're very lucky to have two people on the panel from Georgia. So it'd be great to hear from David and Mariam about the successes that you've had in Georgia and how that was able to get started and what been like implementing it and getting to the point where we are now. So I don't know if Mariam, would you like to start?
With pleasure. Thank you, David. Greetings, everyone. It's wonderful to join the distinguished panel. And the level of expertise around the table is really impressive around the world. As the Deputy Health Minister, during your introduction, you mentioned that I was engaged in the design phase of the Hepatitis C program in Georgia, while the actual launch of the program started in 2015 under the leadership of David Sergenko, who was the Minister of Health at that time. So I will leave the successes of the program implementation itself to David's part, while let me bring up the success factors that actually ensured successful launch of hepatitis C program. And this may also respond to the question that Nigerian civil society activists just raised, how we start, how we reach, how we initiate the hepatitis C programs. So in Georgia's case, let me note that it was a constellation of success factors that actually contributed to the eventual design and launch of hepatitis C. And every piece of the success elements are equally important. Let me just list without the order of importance. First of all, Georgia has built its hepatitis C program on a very strong foundation of other infectious diseases, namely HIV, immunization, and TB. 3 decades ago, Georgia started its HIV/AIDS program and has built a sound diagnostic capacities and treatment infrastructure for antiretroviral therapy. And 10 years ago, we also initiated co-infection management of HIV and hepatitis C that actually accumulated important knowledge, technical knowledge for the Hep C program. In terms of the hepatitis B program, back in 2002, Georgia was one of the first applicants for the Gavi Alliance. So we were able to secure financial resources from Gavi that is readily available for low and middle income countries, and through the financial sustainability plan in Georgia, phased out from the Gavi support, and then the government of Georgia took over the vaccine financing. So vaccines are readily available through international support if the country needs financing, and the treatment of hepatitis B is relatively less expensive and affordable for most of the countries. The second successful factor for the hepatitis C was the actual will of the government, backed up by financial resources. In 2013, Georgian government doubled its health investments, initiated a universal healthcare program, and then started to focus on hepatitis C due to extremely high, almost 7% prevalence rate in the general population. So financial resources were initially invested in interferon-based treatment for prisoners, and 60% cost reduction for interferon-based regimens for every citizen living with hepatitis C, and in parallel with introduction of new directly acting antiviral agents through the Gilead manufacturers. Georgia started negotiation with Gilead through US government support, and international support from our strategic partner was extremely important. The third factor was the soundness, the expertise of the program, soundness with evidence-based and results-oriented approach. From the very beginning, Georgia has established important evidence base through epidemiological and seroprevalence surveys, and with engagement of technical experts from national and international partners, secured technically sound plan with reasonable and realistic results framework and monitoring and evaluation details. Next was the international support. Without the support from WHO, the Hepatitis Alliance, Gilead, US government, CDC Atlanta, MDM, and Open Society Georgian Foundation, success of the hepatitis C program would never happen. And last, but definitely far from being the least, was the active engagement and the role of civil society. Starting in 2013, patients living with hepatitis C were extremely actively engaged in protesting campaigns, and we started with protest campaigns, and then we became friends and allies to make sure that the national response for hepatitis C would be strengthened in the country. And I would like to highlight the role of the civil society through the MDM and the Open Society support. So as they say, it takes a village to raise a child, and it takes multiple stakeholders, real engagement of different parties to succeed in hepatitis C elimination. Thank you.
Help if I'm not on mute. Thank you so much, Mariam. David, would you like to continue?
Yes, thank you. So I wanted to share with you some main points of Georgian experience. So as Mariam mentioned, in 2013, there in global market appeared the AA medicine that was not available before. And there started some global movement that medicines are extremely expensive. And if you would have some affordable prices, everybody or most patients would come, get treatment, etc., etc. Why Georgian experience was important? Because we had zero price for this extremely expensive medicine. And if you could imagine, if I may say, this is like in Discovery Channel movies, Reveal the Ocean. By removing this financial issue, we were able to look deep inside of the program. And we found very extremely important factors, extremely important, that equally important as a financial barrier. So first finding that I would underline that financial barrier is not only barrier, and moreover, this is not only number one barrier, maybe it's second. So first finding that paradigm or slogan that works currently for HIV, early treatment as prevention, is not so right. So actually this is right, but this is extremely compressed slogan. Indeed, there is three-part approach: prevention, treatment itself, and stigma fighting. And these are equally important. Without acting on all these three factors, you cannot tackle, even with free medicines, your target. And maybe later on, if there would be some additional questions, I would answer in more details. Now I'm underlining just the main points. So finances are, lack of finances or price for medicines, okay, or lack of budget is obstacle, but not number one. And the Georgian example teaches to us how to tackle this, because if activists, medical doctors, public health specialists, NGOs are coming to state and saying that you see, people is suffering from hepatitis, let's treat it, let's give to us budget, because otherwise you have to treat liver cancer or we will lose lives of our citizens. Trust me, it will not work, or it work not so efficiently, because again, our example allowed us to look from inside to out, from bottom to top. And this is extremely important. I agree that with Mariam about some main factors of success. There are three main factors out of many others. First is political will, not by number, but with importance. Second is availability of human resources, I mean physicians, scientists, and kind of infrastructure. And third is availability of good international partnerships with several international institutions. All these factors are equally important. And if there is a lack of one of them, and mostly this is political will, it's useless to try to do something, because doing some advocacy, protesting, etc., this is the way. But it's much better to do it with armed information and the right way how to deal with. And again, Georgian example, it's kind of discovery, reveal the ocean, reveal the financial barrier, gives, in my understanding, the perfect solution for this. And because this is important, Georgian example, not because of high rate of linked to care patient, high rate of cured patient, which is of course important, but why we were trying all these years from 2015 to share our experience with other countries, because this is our issue of dignity. This is our honor to share, because we had strong support from others and we have to give it back. And I think these couple of approaches that I mentioned in very short, that I will repeat with your permission. Early treatment as prevention will not work in this case, because it must be enhanced in at least three directions, which are equally important. This is prevention, treatment itself, and fighting with stigma. Stigma to not only patients or infected people's stigma, but stigma from government and non-governmental organizations sometimes. Three kind of approaches, three-part approach, not only early treatment as prevention. And second is availability of three mandatory, absolutely mandatory factors: political will, availability of human resources and infrastructure, and good international partnership. And in most cases, there is a lack of political will. And we, together with Mariam, we appeared very happy people indeed, because government of my country, of our country, was extremely motivated to do this healthcare reform indeed. And we had extremely strong political support. And there is some magic key: if there is a lack of political will, how to fix this problem with engagement of local and international NGOs and several organizations. So what I am trying to describe now, and I apologize for my English, that this is a kind of blueprint, kind of some just a skeleton of the program, and I just try to underline main findings. And later on, if there will be questions, and I have a bit time more, I will gladly answer. Thank you for your attention.
Great, thank you so much. I mean, it's so inspirational, the work that you've all been able to do in Georgia. And I think if people, if we could find the silver bullet to create political will, not just in national governments, but state governments or even within health systems, that would be terrific. And I think what Danjuma said about really humanizing hepatitis elimination, so we're not just talking about bell graphs and cost effectiveness curves, that we're talking about people, and for every vaccine not given, that's a life shortened by hepatitis, and really trying to humanize it so people can empathize and be more compassionate toward people with hepatitis. I think that would take us a long way towards where we want to be. I'm just going to ask the panel one more if they have any comments at this time. Then I'm going to go to the Q&A box. Marco, please.
Thank you very much. So I just wanted to add, so first of all, really impressive work, and thank you for that in the name of the patients. I just wanted to add the development of patient activities. So maybe at the beginning in hepatitis world, we were able to achieve something with a strong protesting on the street, but this is not the way forward. So from my perspective, or from perspective of European Liver Patient Association, so we believe in joint collaboration. So we believe that we will not reach elimination if we do not collaborate together. And collaboration does not mean being on the street, but it means being in the office and trying to find out solutions that would be beneficial for all sides that are at the table. I just wanted to add that. Thanks.
Great, thank you. And that does kind of lead us into the first question in the chat by Han Yang Chung, which the first part of her question is, how do we ensure governments are accountable to hepatitis patients by providing the timely treatment to patients? And the second part of the question is, what would be the role of parliamentarians, and how can patient groups reach out to their policymakers on this issue around timely access to treatment? So would anyone like to speak about how patients can, how we can hold governments accountable to providing treatment? Or how community groups can reach out to their parliamentarians to kind of have those discussions? Danjuma, why don't you start us off?
All right, thank you. I would start by saying that advocacy in low middle income countries like a country like Nigeria or in most of Africa is a totally different ball game with the way advocacy is done in the Western world. In most low middle income countries, most of our government representatives don't owe any act of responsibility towards the citizens. Very poor inclusiveness, very poor citizen-civil engagement in every aspect of governance. So it's very, very difficult for you in most low-income countries. So it's like even in Nigeria now, for you to go and even knock on the door of your parliamentarian and get him to respond to you. because he doesn't even feel he owes you anything. So it's quite challenging for patient groups to move the needle and to get people in government act in most of Africa, like in Nigeria. I know for me, in my role as even a team lead of the civil society, it took meeting some of these people outside Nigeria before they even listen to you. You write letters here, you want to see them, you don't get to see them. They don't feel they have any responsibility towards you. Now, that is a big challenge. However, globally and almost across the world, I think the paradigm is there is a paradigm shift to look at co-creation and patient engagement in the eco-health system. We have a challenge where patients are not really looked at as equal partners in driving advocacy and even in driving access to healthcare. Patients are seen as helpless people, most often who their voice is not even regarded important in driving healthcare systems. And that is what we are trying to change. And that this cannot happen if there's no continuous awareness creation, continuous engagement, probably trainings, but we need to really push more to make policymakers and parliamentarians realize that patients are equal partners in the eco-health system and needs to be consulted and engaged in driving access to healthcare, which is poorly done, especially in low middle income countries where patients are not even regarded as equal partners in the healthcare system. Over.
Right. That's so important, right? That we're just not talking about engaging patients or listening to them, but, making civil society and community groups equitable partners in, the development, the implementation, and the governance of hepatitis programs. It's so important to have effective responses. David, please, you have your hand up.
Well, I agree, of course, that advocacy and the engagement of civil society, individuals, patient society, and community is absolutely important. And this is kind of mandatory part of this movement. But I'm afraid this is not sufficient. This is like in mathematics, this is mandatory but not sufficient factor to do this. What else can be done when there is not sufficient political will? Engagement of international organizations. I mean, WHO is always engaged in such activities, but let me present a couple of examples like Gavi in vaccination, like a global fund in tuberculosis, malaria, HIV, etc. They were providing funding, and you cannot find such funds that they are providing diagnostics and treatment funds, but some international with high authority organization that will promote to the country at least two possibilities: to do some countrywide survey, what's the percent of infected people, and kind of diagnostics and treatment, the diagnostics and training for our local staff. I think it will give not a community-based, not a activity-based picture, but country-based picture, what is a reality. So advocacy, not only on community level, not only on activists level, but on international level. And there are several organizations that we could apply with this idea when it will be structured. Because I'm saying again that based on our experience, only local efforts is not enough. International engagement is key to success.
Excellent, thank you. And Gisela, did you want to come in on how parliamentarians and policymakers and community can work together more effectively?
Yes. Pensaba
I was thinking in what you were saying recently, and we have great opportunities. I like the example that Marco presented, specifically what he said that we can use as a reference with has been done with other diseases and see how we can work within our parliaments. In Latin America, it's not a minor challenge that we need to talk. These transmissible diseases today affect strongly, and they affect overall those populations that are more vulnerable. And this is the central topic, reality, those populations that cannot be, that increases in poor populations, these communicable diseases where we are not able to get there on time with diagnosis. And in our Congress, I see it as the point of view of a republic, not we have to do the effort that in our agenda, in our discussions of the budget, they are necessary to include them. And in this path, we need to talk on how we need to increase budgets, but also how legally this is done by law can be done in another countries, that these treatments can be covered by the state so people can have access to have these treatments. This is very important to work together with civil society in those countries, that we need to focus that the treatments are there, vaccines are there, but also screening and testing on time. And we also have the huge challenge in our Congress or Parliament to talk about the stigma that this disease generates in populations. And this stigma are related with the possibilities to obtain a job or to maintain the job or to have the capacity of a full life. And those are the topics that we can work, and we should talk about this in Parliament, especially because I self-criticize. We don't talk in the senators or Congress chambers. We are leaving them on the side. We are doing what we always say, what needs to be done, and to invisibilize these diseases. We need to visibilize these diseases. Just changing a little bit some laws and to take away the stigmas that are associated with this disease. As some of you say, some have more publicity or marketing like HIV, while others are forgotten and are not visible. And in this path, it's our challenge that we need to work together with civil society and to insert it in the agenda. And on July 28th, we need to be a voice of this disease that do not have a voice. Thank you.
Thank you so much. And I think, I think it's hard to underestimate the impact that stigma has on all aspects of people living with viral hepatitis life, but how it creates barriers within health systems and within parliaments and within decision making. It really is a huge thing that we need to tackle. We just have a few questions in the chat, so I want to make sure that we can get through the questions. The second one from an anonymous attendee says, how can parliamentarians help to ensure that HCV treatment costs can be made at an affordable level? Compulsory license perhaps can be a policy tool that governments can use to ensure the country has access to affordable treatments. Anyone like that?
Yes. Corey, if I may attempt, answering, that question.
Yes,
maybe
please.
from a perspective. Although the person has made his own, suggestion, having a license, left me, I would say, issue of insurance is a way that can really help, to mitigate, to reduce, the burden, on people, on patients, having to pay, a lot of money. For instance, in Nigeria, we have the National Health Insurance Policy, but unfortunately, the coverage for a very long time has been very poor, has been very low, almost about 4-5%. out of a population of about 200 million. You can really imagine, that. So we need legislation, to change, to amend the present health insurance policy in Nigeria, which will make it compulsory to cover majority of the population. Now, this national health insurance is at two levels also, the federal level as well as the state level. If all the states, the 36 states of the federation in Nigeria, for instance, can come up with insurance, scheme, having money, available for people within the rural areas to make this available, to make it, cheaper, to make it easier for people, to have medication on hepatitis. It will really reduce this burden. So the best way to go about it is legislation. Through legislation amending the National Health Insurance Act at the federal level, that's in Nigeria, level, while instituting the same at the subnational, level to make it easier for people, to get attention. Because as it is really, in fact, many of the states government today do not even have budget line for hepatitis. Really. So legislation is a way. The major role of a parliamentarian anywhere in the world is first to make appropriation to available funding, for this really. So it's the best way. Thank you, Kari.
Excellent, thank you. Anyone else from the panel like to address that question? Mariam?
Thank you for this important question, and that's the purpose of discussion definitely today. So let me note a couple of approaches that the parliamentarians could imply. First of all, based on the experience from vaccine procurement or antiretroviral procurement or TB, diagnostic or treatment logistics, parliamentarians can discuss voluntary collaboration with international pooled procurement or consolidated procurement mechanisms, or to ensure that Doha Declaration principles are applied to the hepatitis C treatment regimens. At the international level, we have secured that hepatitis is on the agenda of both universal healthcare political declaration and other international commitments. So the international stakeholders should also ensure stronger monitoring of national policymakers in terms of meeting the international commitments to hepatitis or B or C elimination efforts. Finally, let me note that today we had a very interesting case when, even though David Sergenko and myself, we started together the hepatitis C elimination, a couple of years ago, I moved from the ruling party to the opposition political party. And we should ensure as policymakers that health agenda and hepatitis elimination agenda is a bipartisan, pan-partisan issue for every politician in the country. So maybe this is an issue like COVID to unite all the different representatives of political, parties around common declaration of commitment that Hepatitis Alliance and Unite could initiate with other stakeholders, and to make sure that irrespective of our political positions, we sign the commitments and make sure that we meet the commitments for hepatitis elimination.
Great, that is excellent advice. So we have a question that kind of leads from Dr. Usman's comments. It says, what is the key to a successful rollout in rural areas, not just big cities? I don't know if anyone has any comments about rural areas. I know this isn't really a technical webinar. But does anyone have any thoughts about bringing these things to rural areas as opposed to just urban centers?
Thank you. I'll still give an example with Nigeria and also with most of our low middle income countries. The challenge we have is the challenge of infrastructure, and then the lack of decentralization of care to secondary and primary level of care. And that is where you have majority of the higher level of populations. So the best way, of course, is decentralization trainings of more healthcare workers so that it doesn't become specialist kind of cascade of care. And using the WHO approach of public health approach, that's what we're running in Nigeria now to ensure that at every level, secondary level, primary level, the GPs and the healthcare workers at that level will have the competencies to deliver. But the challenge still remains, Carrie, that if you look at, for example, diagnosis capacity at that level of care is very, very non-existent in most of our countries. So that is where we'll have challenge in even elimination, because at the level of primary care, there's very poor diagnostic infrastructure, especially I'm talking now in the context of Nigeria or most low middle income countries. So that becomes a huge challenge and a problem to programs, even at the national level. So there's need to increase investments to ensure that the infrastructure at the lower level of care, at the community level, is strengthened, and capacity of healthcare workers at that level also needs to be enhanced so that populations at that level will still access quality healthcare in the context of what we're talking about, universal health coverage. So capacity building, system strengthening, to build infrastructure, laboratory diagnostic capacity, healthcare workers' competence and knowledge at that level of care is one way to go. Then finally, to look at this challenge, we have very poor ownership to drive, let me use the word domestic commitment of financing to drive hepatitis elimination. The example of Rwanda and Egypt, where they registered pharma companies locally, where they could produce those drugs locally. That is one way also I think most countries in Africa could succeed in drawing the attention of most of these companies to locally produce these drugs in their countries, or even to have point of care diagnostics, which of course will enhance systems at the primary and secondary level of care. Thank you. Over.
Agrego algo muy pequeño.
I want to add something. For rural populations in Latin America, we can learn a lot on COVID, because COVID is going to provide us an important lesson, how we're able to monitor a disease, how we were able to register cases, and how to reach populations that did not have infrastructure. So we will learn a lot on COVID to think forward. And I think that vaccination for COVID also will provide important lessons that it is possible to reach those isolated or remote populations. So we will be able also to bring treatment and effective results for hepatitis and to eliminate hepatitis. I think that COVID can provide us valuable lessons, and we will be able to learn and draw from these lessons after the pandemic, and we can look back to that experience.
Excellent, thank you. Yes, I think the experience of COVID will hopefully provide us with some opportunities to grow and to evolve things faster than they were before. And so some good can come out of this really terrible situation the world finds itself in at the moment, right? Okay, so I know that we're kind of over time, but I just wanted to bring in Chris Munoz from the Philippines and his comment, and maybe we can just finish with a roundtable, tour de table about one of his questions. So Chris says, I agree with my friend Marco. This was for a previous. We can't be compared to HIV patients, and we have our own way of producing results. Bottom line is, what will it take for a parliamentarian to take on our advocacy? Does it really have to be seeing people rallying in the streets rather than sit down at a table and discuss issues and challenges? We had a discussion last year, and it seems we are still where we are in 2020. So I guess maybe we can just address briefly Chris's question. What's one thing that we could do to to kind of move hepatitis along in parliamentarians, or what will it take for parliamentarians to take on hepatitis advocacy? Would anyone like to kick us off? Or I can.
Yes. If I may comment once more.
Yes, please.
Parliamentarians must always be reminded of their basic responsibilities, basic functions, which are three. First is appropriation. It's the major function of a legislature, a parliamentarian, to appropriate, to ensure that funds are made available for many things. But this time around, priority must be given, to health in terms of ensuring budget line for it. In many states in Nigeria, even at the national level, I assure you there is no budget line for hepatitis. So we must work with all the civil society organizations to call on the parliamentarians to ensure that that is really done. That's number one. The second thing is at both national and subnational level, incorporating medication in the national health insurance scheme at both national level. Of course, the third is the oversight functions. Functions here means going down to ensure that our primary healthcare centers are functional at the lower level. That is where we say majority of our people, stay. That's where they live. They require support, assistance, access to medical care. So our legislatures must ensure that they go on oversight. All these things are available. These are some of the key messages which I feel we should really resonate with our parliamentarians. Thank you, Gary.
Excellent. Thank you. Mariam, would you like to go next? What's the bottom line? What will it take for parliamentarians to take on hepatitis advocacy?
As I mentioned, and I fully agree with Marco, we started with protests on the street from hepatitis C patient groups, and we became partners around the table. It really takes a goodwill and even with financial constraints to start the dialogue, to really agree on the common agenda and start to planning and fight for the common good of the country. By the end, it's our common country and the population that we have to take care of. And my last comment is that I think that it's high time to really ensure that HIV, TB, and malaria response without the Global Fund financial pledges and investments, cost reduction for the drug regimens or diagnostics would not be possible. So we definitely need to consolidate international effort for finding a global funding mechanism for hep C diagnostics and treatment.
Excellent. Yes, a global mechanism would be so helpful, and something that we're all working furiously kind of behind the scenes to try to make happen. But yeah, totally agree with that one. Gisela, would you like to make an input?
Muy corto, creo que los parlamentarios.
Very brief. I think that parliamentarians, we have learned that isolated and alone in our countries, we cannot aspire to gain good results. We have to think in health as a global approach, using our cooperation and mechanisms, our regional mechanisms. But as Mariam said, to utilize all the parliamentary networks and all the options that we have for financing, for support for our communities, but overall to work from the standpoint of our parliaments in comprehensive approaches to health, understanding that the health is a priority And today we have this opportunity to set it in the agenda of global leaders. This is a unique opportunity. We have to talk about the multilateral roles in the international organizations and the role that they have or they play in our countries, and to really put pressure so we can overcome differences. For example, in vaccination, we know that vaccination is failing in some of the countries in our region. We face huge challenges, and thank you for this invitation.
Excellent. Thank you so much. And Danjuma and Marco, if you have maybe a final comment as well, please. Marco, why don't you go first?
Thank you very much. So I just wanted to say two things, and I will elaborate a little bit on their behalf. So first, do your homework. And second one, think out of the box. So do your homework. This is really a message for every who is involved in public diplomacy. So you should know who got elected, what part of his program is devoted to health, which parts of the health program are devoted to hepatitis or similar things, and how you can approach this. This is like the part that is do your homework prior to contacting any parliamentarian. And when you got into contact, you should think out of the box. So out of the box is you can use the official channels, which should be used as a first step. But on second step, you should try to find out how to reach out to the persons who are interested in your health issue in any way possible. So on a golf course, or maybe at a picnic where you have an opportunity to really just say a few words just to spark interest, and then you have the opportunity to present something. And when you have the opportunity, you need clear data. You need data that comes from medical experts, that comes from the sources that were several times mentioned here. They need to be clear and concise. And that is like just two things. Do your homework and think out of the box. Thanks.
It's brilliant. Grab every opportunity, right? So look out if you're at a picnic, parliamentarians, we're going to be coming after you. Danjuma.
All right, thank you. I want to re-echo what Mariam said. And I think my candid opinion is that, yes, we have a lot to benefit, to learn from HIV. We have a lot to benefit from HIV infrastructure. But I think hepatitis has lived in the shadow of HIV for too long, especially in terms of funding. And that is really a big problem. We cannot move towards elimination of hepatitis if there's no global funding for hepatitis, if there's no mechanism for global funding. We will not achieve that goal. We'll still keep saying this for the next 10 years. We'll still come back and have webinars, and people will not have access. So even in clinics, there's still the issue of identifying hepatitis patients. What about mono-infected patients? I'm a mono-infected hepatitis B patient, so I cannot benefit from the HIV infrastructure, basically. But so unless we have a global funding mechanism for hepatitis elimination, believe you me, I mean, it's really unfortunate that we cannot move towards elimination of hepatitis. That is my candid opinion. And thanks for this forum. Over.
Great, thank you, Danjuma. So that just leaves it for me to maybe sum up. I mean, I think it's been a really great hour and a half of discussions. I mean, we started out with Gisela talking about, the importance of prevention and communications, and obviously how COVID-19 has kind of moved the health agenda along, and the importance of hepatitis, the hepatitis movement to move along with it and look for those opportunities. And Mr. Usman from Nigeria talked about the barriers in Nigeria around service delivery, and especially around vaccine hesitancy. And of course, that's also a major issue is the COVID response as well. And Danjuma very eloquently talked about how we need to move beyond the status quo in hepatitis elimination to move forward, and how the human angle, how the impact on individuals has to be brought out, because we're not just talking about numbers or targets or statistics. We're talking about human lives here. And I think that's really important in order to generate that empathy that needs to happen for people to really stick their head above the parapet and make hepatitis their cause within their parliaments or within their decision-making bodies. And Marco talked about the real importance about linking hepatitis to other conditions like liver cancer, and the great work that they've done on the European Union level just to do that. And then, of course, we heard about the amazing program from Georgia and Mariam started out about talking about how important it was to build on existing structures. So not necessarily start from scratch, but look at things like existing screening and treatment structures, maybe from HIV and TB, and how that can be an amazing starting point to build a program. And then David carried on talking about the Georgian experience and talking about 3 key factors to their continued success, which were political will, human resources, and really making those really important international partnerships. And I think, David, just to close with this, with the point that really came up, that, you know, patients need to be equal partners with parliamentarians, within health programs, in the development, the delivery, and the governance of these hepatitis programs. And I know that we're moving towards our goal. And, you know, Chris has kind of mentioned that can be frustrating sometimes about the speed, but it really feels that there's momentum or behind hepatitis elimination, both on a global and on many national levels. And we have to keep on saying that we can't wait any longer for, you know, hepatitis to be acted upon. And this World Hepatitis Day, Hep Can't Wait, is our rallying cry. And we'll be continuing this campaign beyond World Hepatitis Day, so we can continue to make these points in parliaments and in picnics and in health centers, and, you know, to really try to make us one step closer to our 2030 goal. So thanks again to everyone. Please fill out the evaluation form that you'll get with the link for after the session. And I just wish everyone a very successful World Hepatitis Day. And thank you again, everyone. And please attend our next webinar, which is on Monday, which is at 1400 GMT, which is Youth Can't Wait. So it's going to be our first youth-centered webinar, really bringing together advocates from around the world, talking about the impact that hepatitis has on young people, and how we can mobilize the huge energy of young people to help fight for elimination. So thanks you everyone very much, and hopefully see you next time. Thank you.
Thank you.
Bye. Thank you.
Thank you very much.